Okay, so we shall just give it sort of 10, 15 seconds. Let's see if people are making their virtual way into taking the seats that they've probably already taken because they're usually sat at a computer or on the phone or something. But yes, I think I can see there's people on the way in, which is great. So maybe we can get started. Hello, everyone, and welcome to today's webinar focusing on pain and mental health. I'm Nathan from the European Pain Federation EFIC, and you join us live today on World Mental Health Day. And we're going to explore the double burden of mental health that we feel Europe must address. And to do that, we're collaborating with the European Psychiatric Association to bring you what I think will be a very insightful and interesting discussion. You might see on your screen that we're joined by a few panelists today who we thank hugely for taking time to share their thoughts and their opinions. But there is a little bit of housekeeping before we get into the presentations and the discussions, though. So like all of our live webinars, there's a Q&A function at the bottom of your screen where you can ask questions throughout the presentations and of course, the discussions towards the end. We'll do our best to get to all of the questions and give you a chance to interact with today's content. And you can also do this anonymously if you like to. I like doing that sometimes as well. If you would prefer, you can do that, of course. And we'll go over all of those questions and comments and discussions after the presentation, so we get plenty of time to go through what we want to go through today. There's also a chat function that you can use for general comments and wider discussions. And actually what we like to do at the beginning of these webinars is we like to get an idea and a flavor of where everyone is joining us from. So if you're joining us live, of course, we'd like for everyone to just post in the chat very quickly. Let us know perhaps what your role is very briefly, and of course, where you're joining us from today. We'd love to find out, and I'll keep an eye on the chat about where everyone is joining us from. So it's also worth mentioning that if we have any materials or resources, we'll post those in there as well. A reminder that this is also a recorded webinar, so you can access these discussions at a later time with a cup of tea or a cup of coffee, of course, if you wish to do so via the EFIC Academy, the YouTube, and then, of course, the online resources from our partners today, the European Psychiatric Association. So super excited to get involved. But before we get started with the presentations, I'd love for us to have an introduction from everyone who's involved today. I can see from the chat, actually, we have people from Nigeria, medical professionals from Belgium, from London, the UK, Staffordshire, some more Belgium, Exeter, Nigeria. Brilliant. It's great to see everybody here. Thank you so much for joining us. So I'm going to hand it over to our panelists just to give a very, very quick introduction to themselves. Maybe we can go straight to Professor Don to give us an introduction to the EPA. Again, very, very good morning to you. Thank you so much for joining us.
Okay, Nathan, it's a big pleasure, and hi to everybody. Nathan, help me. Is this the moment I introduce a couple of slides, or I just say something?
Yes, feel free. Go ahead. If you want to share a couple of slides, we can absolutely do that.
The visual is always helpful. So bear with me and give me a yell if you see my screen.
Absolutely.
You see my screen?
So we can see the full screen. I don't know if you want to jump into presenter.
Do you see like this here? Yes.
Absolutely. Ready to go.
So ready to go. So very happy to be here on behalf of the EPA, the European Psychiatric Association. I'll shortly go through two topics. What is the EPA, and then the topic of today. So my name is Gerdom. I'm from Belgium, Antwerp, beautiful city. And I'm the immediate past president of the European Psychiatric Association, which is, I think, and this is a little bit PR, but important, I think the main association representing psychiatry in Europe. In a nutshell, we represent about 80,000 psychiatrists throughout Europe, which is important because Europe has about 90 to 100,000 psychiatrists registered. So we have about 80% of all European psychiatrists where we have contact with through our 47 national psychiatric association. Of course, we do a lot of work scientifically, education, etc. But you can find it on the website, and I'm always obliged to make a little bit PR for our next Congress in Prague, so very welcome to that. But to the topic of today, and I make a little bit of speed, please remember all of us, it is today the World Mental Health Day, 10/10. And so excellent choice for EFIC. Patrice, thank you very much for organizing and for asking EPA to join, because it's an excellent moment. It is today World Mental Health Day. And in that respect, I really stress two things. Below on the panel, you see the recent data from the WHO saying that at this point, and it's the first time in the history of human life and evolution, we have more than 1 billion people living with mental health conditions, which is huge, huge. And on the other side, and that's for the EFIC side, we live in a kind of not so much hidden anymore, but epidemic of chronic pain. Figures vary, but at least 2 million suffer from it. And there is this big overlap between having chronic pain. So people having chronic pain more often have also mental health issues. And as Anna, Dr. Kopa will explain also, persons with mental health issues have more than the mean average of chronic pain. So we live in two disciplines that are closely interconnected. And just to highlight this is just out released in Nature, I think 2 days ago, which is an interesting article. It is, of course, animal research, but again highlighting how closely on a neurobiological level these two domains are linked in this with the neuropeptide receptor and also with the interaction between having these hunger, thirst, cues, etc., that can suppress. So the interaction of mental things and how it influences pain. Just to highlight it, but I'm very sure that Dr. Krupa will have a brilliant presentation showing this a little bit more. So thank you, EFIC. Thank you, Patrice. As EPA, we are really happy that I think the European Pain Forum started in 2019, something like that. I'm not sure if I remember well, but happy members of this very important event. I just highlight these couple of clinical practice recommendations we all work together on. So much work to be done. So this is for my short minutes of introduction. Nathan, the floor is back to you, and I looking forward to the rest of the webinar.
Brilliant. Thank you so much. It's a comprehensive introduction. It's what we like to see. Thank you so much for being here. Maybe we can hand over to Anna. Welcome, Anna. Tell us a little bit about yourself.
Yeah, it's very good to be here and to have the opportunity to discuss this topic. I am a psychiatrist. I'm based in Poland at Jagiellonian University Medical College in Krakow. I also represent EPA as the young researcher. And about myself, I did my PhD thesis working both clinically and in research in people with fibromyalgia. So really the topic of comorbidity of mental health and chronic pain is very central to me.
Brilliant. And it's really great to have you here. Thank you so much to both of you for spending time with us today. Maybe I can see lots of people coming through to the chat, which is fantastic. We'll catch up in a moment. Let's hand over to Patrice. Patrice, welcome. Thank you so much for being here. If you have a couple of slides for an introduction, please go ahead and do that. If not, just an introduction to who you are and what you do. And a brief introduction to EFIC as well would be really useful. Welcome. Thank you so much for being here.
That's great. Thank you so much for all of you to being with us today. Thank you, Nathan, for the great job you've done. I will just share indeed a few slides to basically show who am I. That's not what I want to do. So yeah, okay. Who am I and why I'll speak not too much about me, but about SIP, also because it's definitely not about me that I would like to insist on, but about the importance of the interaction between pain, mental health, and about the people living with pain and with the conditions. Just about me, but very briefly. Obviously, I'm to some extent representing EFIC. EFIC is an organization representing 20,000 professionals working in the field of pain. I'm initially trained, I've been initially trained in Belgium in anesthesia and pain, and I moved 6 years ago to the UK to Aberdeen, which is, by the way, like Antwerp, quite a nice city. And so it might be good definitely to continue to encourage that kind of interactions at the European level and help people to understand different perspectives in different contexts, because science may be the same, but implementing, operationalizing that, and being sure that it really addresses people's needs definitely benefits from this kind of multiple perspectives, and traveling for that definitely helped me. In my clinical academic life, in research, I'm focusing on what we can do and what we shouldn't do as well. So quality and safety of pain management is basically what I'm working on. And SIP, and that's my last slide for the moment. SIP is much more than that. That's a partnership between what EFIC does and Pain Alliance Europe and patient organization. So I'm very happy to do that with Lisa Jutila, who's the vice president or the ex-vice president and board member of Pain Alliance Europe, which represents more than 400,000 people living with pain in Europe. And that's a very important perspective to try to distinguish not only what we can do, but more than that, what we should do. And that's by partnering with people living with pain that we can actually properly deliver that, and then going back also to policymakers to raise awareness on the problems that really matters to people. So that's all for me for the moment. I'll stop sharing. I'll have a few other slides later on when we'll want to enrich the discussion. Thank you.
Brilliant, Patrice. Thank you so much for joining us. And again, to everybody for being here. We have lots of people in the chat who have already engaged, which is great. We have Amy, Lydia, Mona Lisa, Ariana, Danielle, Leanne, everybody's here, which is fantastic. So thank you so much for being here and engaging, letting us know where you're coming from. As a reminder, you can obviously ask questions throughout this webinar in the Q&A function, and you can do that anonymously as well. That's enough for the housekeeping. I think let's get into the content, shall we? Let's go ahead and begin with presentations from, of course, our partners from the EPA today. Do you guys want to go ahead and share? And thank you so much for sharing your insights today. I'm looking forward to this.
Is my presentation visible?
Yes, it's not quite in presenter view yet. There we go. Perfect. Thank you so much, Anna.
All right. So once more, thank you for being here and discussing this very important but under-discussed issue of what role a psychiatrist can play as part of the multidisciplinary team which manages the dual burden of mental health and chronic pain. Well, first and foremost, the numbers that Professor Dom mentioned. We need to be aware of the fact that people with chronic pain are at a much more higher risk of various mental health issues than the people representing the general population. Well, the most discussed ones, which we often mention are major depressive disorder, anxiety disorders, which are 2 to 3 times more common among people with chronic pain than they are in the general population. But please be mindful that almost 80% at some statistics of people with chronic pain also suffer from impaired sleep, and also other comorbidities which are less researched but also significant and more common in this population of people with chronic pain are, for example, somatic symptom disorder, personality disorders, neurodevelopmental disorders. For example, ADHD is estimated to affect some 4% of people in the adult general population, but in people with chronic pain, it is from 15 to 25%. Furthermore, PTSD and opioid misuse and dependence disorder are much more common amongst people with chronic pain. And so the mental health burden is very common in this population. Next, we need to be aware that mental health issues and chronic pain share common physiopathology. Now, for this presentation, I am mainly going to discuss depression, anxiety, and sleep, as to stay focused and not be too complicated. For example, we need to be aware that the brain structures which are responsible for signaling pain as well as regulating mood, anxiety, and sleep-wake behavior, do in a large extent overlap. Now, these structures would be thalamus, cingulate gyrus, insula, amygdala, periaqueductal gray, and somatosensory cortex. How are they linked together? Well, the monoamine neurotransmission, mainly serotonin and noradrenaline signaling, is impaired in all of these conditions. And furthermore, it is normalized by antidepressant action, which leads to decreased pain. What are the other ways in which mental health and pain are intertwined? Where there is imbalance between excitatory and inhibitory signaling in the brain, which is directly linked to pain catastrophizing in people with chronic pain. More recent studies have also shown that both in depression, anxiety, or insomnia, as well as chronic pain, we do see a shift in the functioning of the immune system towards pro-inflammatory action. And while we do know in psychiatry that depression is closely linked to the BDNF levels, more recent studies have also shown that it is lower in people with chronic pain, and some works even assessed it as a potential biomarker for chronic pain. So the physiopathology is certainly, to a large extent, common. Now, if we were to focus on particular mental health issues and how they are linked to chronic pain, let's start with depression. People who are suffering from depression and chronic pain, compared to those who do not have depression, are unfortunately burdened with high pain disability, higher risk of other somatic problems, higher risk of hospitalizations, and they are at a lower chance of achieving good treatment outcomes. And on the other hand, people with depression as their primary disorder are more likely to suffer from various pain complaints. It is estimated that 2/3 of them suffer from some sort of pain, and as much as 33%, there is no other underlying cause to the pain than the depression. Those people are also burdened with longer duration of depression and higher severity of the depressive problems. There's less chance of good treatment effects in this population, and these people are also at higher suicidal risk. If we were to focus on the bidirectional link between anxiety and chronic pain, well, in people with chronic pain, anxiety plays a significant role in this transition between acute and chronic pain, so in the pain chronification. It is also linked to lower sense of self-efficacy, lower activity and functioning, and in result, it leads to higher levels of disability. And in turn, people who suffer from anxiety present a lower pain threshold, high pain intensity, and they report that the pain is more unpleasant for them than to the people from the general population. And finally, what are the links between pain and sleep? Well, those with chronic pain who are also burdened with sleep impairment are characterized by higher pain sensitivity, higher pain generalizability, which means the pain is more likely to be widespread. It is also linked to higher disability linked to the pain, and it is linked to the lower chance of treatment response in people with chronic pain. And in turn, people who suffer from insomnia or present the evening chronotype, which is the preference for more for activity and awakeness in the later times of the day. These people are at the higher risk of chronic widespread pain, and they present lower pain thresholds and lower pain tolerance. And while these interrelations that we have just discussed can be neatly placed when we talk about just two comorbidities, we need to remember these often occur in the same patients, and we need to be mindful of all of them to provide the best treatment effect for these patients. Why is it so important? Well, because if we do not address all the issues that are burdening this patient, we will be posing them at the risk of cumulative burden of them. We will be posing them at the risk of getting into that downward spiral, which is linked to lower treatment adherence and effectiveness, worse somatic health, worse activity and self-efficacy, and eventually this will result in impaired functioning and quality of life of these patients. So it is really crucial that we intervene in all the clinical needs that this patient has. Now, if we're discussing the role of psychiatrists and the management of people with chronic pain, we should be mindful that the treatment interventions are to a large extent common. First and foremost, the patient education, the pain neuroscience education, which includes some education on the aspects of mental health, is effective in reducing pain, avoidance, catastrophizing, and improving activity and functioning. It is the base interventions that has really good effects. Furthermore, certain psychotherapies, such as cognitive behavioral therapy, have been shown effective in both particular mental health issues, which can be comorbid with pain, but also in addressing some pain-specific related issues, such as catastrophic thinking, kinesiophobia, or avoidance. Mindfulness-based interventions have been shown effective to reduce pain and improve depression and quality of life in these patients. And finally, the acceptance and commitment therapies have recently been shown to improve the functioning, the depression and anxiety in patients with chronic pain. Now, these non-pharmacological interventions are one thing. There are also pharmacological interventions which are shared between psychiatry and chronic pain. For example, the antidepressants, the inhibitors of serotonin and noradrenaline reuptake, have been shown to be effective in people with chronic mental health with no mental health comorbidity whatsoever. And it is obviously, understandable given that they have common physiopathology, but it is something that we don't often discuss. Such drugs such as alpha-2 channel receptors blockers, for example, have been shown to be effective in chronic low back pain or in fibromyalgia. Now, we do know they're effective for pain, but we need to always take into the account this comorbidity and address the pharmacotherapy so that it covers all the needs of these patients, because a patient who has comorbidity of insomnia will not have this need covered by the SNRI, for example. A patient who has a depression will not have this need addressed by an alpha channel blocker. And so to get back to this idea of what we can offer as psychiatrists, well, we can help navigate the appropriate choice and use for the psychotropic drugs. These have been shown effective in not only fibromyalgia or chronic low back pain, as mentioned earlier, but also in neuropathic pain, migraine, tension, headaches, burning mouth syndrome, osteoarthritis, and chronic pelvic pain. Furthermore, we can serve as referral points for the appropriate psychological or psychotherapeutic interventions. And finally, but most obviously, we should help manage the comorbidities of mental health in people with chronic pain, which are much more common than in the general population. Now, as a clinician, I would definitely say that there is a need for a more systemic recognition. We do appreciate that the European mental health strategy recognizes the impact of biological and psychological factors in mental health, and that it stresses the need to account for comorbidities and disabilities in order to develop effective treatments. But we do have more needs. We need to raise the awareness of the bidirectional or maybe interrelational links between chronic pain and mental health. We need to integrate the clinical care for chronic pain and mental health. We need to also be mindful of evaluating pain in people with psychiatric disorders. We need more specialist education. And as a psychiatrist, I am mainly focuses on the psychiatric curriculum and the more need for focus more on pain. We also need definitely more funds on the research with comorbidity, promotion of strategies which would reintegrate people with chronic pain into work. And we also need to develop policies to navigate all these actions. So what I would like to stress the most after this presentation is that chronic pain and mental health share common physiopathology, that the dual burden of chronic pain and mental health issues leads to a higher pain disability, lower treatment acceptance and effectiveness, and higher morbidity, and it all ends in the impaired quality of life of our patients. And the treatment strategies for chronic pain and mental health do overlap. And so psychiatrists, as well as other mental health specialists, I'm aware we do have a lot of psychologists here, and I'm very happy to hear that because psychotherapy is a very important intervention in chronic pain. They need to be integrated into the multidisciplinary teams which manage people with chronic pain. And with that, I end my presentation, and I thank you for your attention.
Thank you so much, Anna. Really interesting and comprehensive in terms of justification for why we're doing this today and why we're making these discussions. As you mentioned, lots of psychiatrists and people with that specialty in the chat, so please come forward. Let us know your thoughts. Let us know if there's anything that perhaps we need to focus on specifically, perhaps further, and we'll come to those discussions after. And of course, just as a reminder, you can do that in the Q&A function anonymously or within the chat, and we'll keep track of those. But thank you again, Anna. Really interesting stuff. Okay, let's move on to our second presentation. Patrice, would you like to go ahead? Thank you so much for sharing with us today.
Thank you. Thank you again, Nathan. I'll go there, go to presentation mode and make that visible. Thank you so much. So following Anna's presentation, I'll just open some avenues and explain you what we have done to address the very important need that Anna has presented, and what all you can do. So not only what we have done at the European level, but hopefully making it possible for you to think about concrete action, an action plan that we may implement more locally, echoing what can be done at national and multinational level. And I will come with a few examples of what we have done at the EU level. So the social impact of pain platform, as I have said, is a multi-stakeholder platform led by EFIC and by Pain Alliance Europe. And that's very important to have this partnership with patient and patient representative, patient organizations, to be sure that we actually address the problem we should. The aim is to raise awareness. That's a first and very important deliverable when we speak about advocacy. So a first step is to raise awareness, because for many people, and especially for our decision makers, it's not always that simple to understand the problems we should address to raise awareness of pain and change pain policies in particular. But I will speak, of course, today about the interaction and the co-occurrence of pain and mental health disorders. We collaborate with people like you, as healthcare professionals, but patient advocacy group, policymakers, and more than that. And for many of us, the frontier is not always that clear. We may have different roles as well. Sometimes healthcare professionals have also lived experience, and that kind of interaction may also enrich the dynamic, the perspective, and the discussions. Our sponsors do not have any role in the governance of SIP, but that's important to acknowledge that the industry, and in particular Greenatal, GSK, and Helion, are supporting the SIP platform. We have published a number of white papers and joint statements. And in particular, of course, I would like to highlight this one on pain and mental health. You can scan the QR code, but you can easily find that in open access on the web. It's quite easy to find. Please do not hesitate to contact us if you didn't have or wouldn't have the time or the capacity to scan the QR code today. Very short summary. we wished in this document to highlight the significant link between pain and mental health that has been now clear and extremely well explained by Anna. But that kind of document is also aiming at explaining that to people without necessarily a scientific, academic, or healthcare background. So that's also possible to use that as a dissemination material for making that more clear when we want to raise awareness on that kind of issue and the potential options we have when speaking with policymakers at national or at EU level. Where we have called to better integrate pain and mental health services, that has been an important aspect of Anna's presentation. And this better integration, we strongly believe that it can improve quality of life, reduce stigma, and I will speak about that, and lower health and social costs. Just to remember that pain costs represents about 4% of the GDP, and if we combine that with mental health disorder, and especially for the most vulnerable people who suffering from both, the costs are just enormous and unacceptable when we think that some of these issues could be better addressed. So in this paper, the main SIPs recommendation were first integrate pain and mental health services, so perfectly echoing what Anna explained. Treating them in isolation is simply not acceptable. And we know that unfortunately, because of the current structure of healthcare, it's often the case where care is organized or is siloed, and then people may be or psychiatric patient or pain patient, while obviously many of these, because being vulnerable in their condition, may suffer from both, and each of them can or they can aggravate each other, and they should be considered together. That does mean that the second recommendation is also important because it's not only the system structure, but it's also the education of professionals. And we have a role there. All we have a role because if being together today, that's because we recognize the links between pain and mental health, but we know that raising awareness on that and going further than raising awareness, but educating our colleagues and supporting them because they may feel disempowered sometimes, it's important to improve the quality of care that's delivered. The third recommendation is not only about improving quality of care, but also access to care. And unfortunately, it's often offered quite late. And all we have, or we may have in mind, some experience of people living with pain or mental health disorder and being quite far in their journey, while it may have been easier to address the problem of vulnerability to mental health disorder or pain, and the combination of both earlier, it may have been easier to address that and then not to act potentially in a primary prevention a strategy, but also in a secondary prevention when things are installed, but to try to prevent the consequences of that and the impact of that on quality of life of these people, but also their families. Involve people with lived experience is the fourth recommendation, and that's quite obvious. If we do not do that, we may miss the point in many cases. Just an example, integrating services in primary care, secondary care, what has to be done closer to people living with pain, what has to be done on the workplace, what has to be done in secondary care. All these different aspects are very important. An aspect that's often highlighted by patients is the communication between primary and secondary care. And that's our responsibility. We cannot neglect that. And improving the way we communicate directly with patients, but also between professionals may help to clarify things and making it possible then to have less problems, miscommunication, complicating sometimes care and understanding of the issues. And one of the problem that we see quite frequently when misunderstanding happens about conditions is stigmatizing people. People definitely feel stigmatized, while obviously that they have the right not to feel well when they have pain, and psychological vulnerability is obviously aggravated by pain. And obviously, when they have a mental health issue, they also have the right to suffer from pain, and obviously that they may cope less well with that pain. And too often we see still these issues regarding pain is psychogenic, pain doesn't exist, it's in your head, things like that. Issues with medications have been also highlighted, or you may take an antidepressant, so that's purely psychiatric, or this person take opioids and is dependent on that, and it may be again unfortunately a good reason to stigmatize people more than to support them. So what we did concretely with SIP, we engaged, so that's quite technical, but that's to explain that we can change things. We engaged at the EU level with the rapporteur and the shadow rapporteurs, the SANTI subcommittee report on mental health. And we actively engaged with them. And finally, about 25%, 25 amendments were adopted in the Santé Mental Health report on those by NVI on the 7th of November 23. So actually, we can influence policy. It's a marathon, it's not a sprint. We have to continuously get back to them to influence the mental health agenda. But we have seen how fragile this agenda are. So it's definitely something that we have to continue, that we can do much better together than isolated. We have published some reports, so going back to the healthcare professionals and the scientists, there are many researchers with us today. That's important to have this bi-directional communication between clinicians and researchers, and partnering with patients, and with patients making their voice visible, including in scientific journals, is something that we considered important. So the pain and mental health comorbidity short paper is a paper where we briefly reviewed the evidence that has been discussed today to make it clear that there is clearly an interaction between these different approaches. And finally, influencing policy is definitely something we can do by doing that more and more. And this is also something that you can consider at local level as well when considering implementing national or international guidelines in guidance document, or just at the system level, when thinking about the pathways and the way you may integrate mental health and pain care. Thank you. And I will stop sharing my screen and go back to all of you. Thank you, Nathan.
Brilliant, Patrice. Thank you so much for sharing that. A lovely perspective from the important work that SIP is doing and has been doing and will continue to do over the time. Thank you so much for the presentations, guys. We'll move on to the discussion now, which gives us plenty of time. There's been lots of talk in the chat, which is really helpful. There's a couple of really interesting points, and I can see here that you've engaged with some of those as well. But maybe we can begin the discussions around those. Just as a reminder, everybody can, of course, submit your questions. You can do this anonymously as well. So one of the initial points that came up from the chat was that in highlighting this importance of recognizing the relationship between mental health and pain, research actually is really struggling to kind of capture that and really guide us in the best solutions for this. And there was one comment, of course, from Holly in the chat talking about nearly all the trials excluded in the recent Cochrane review, people with mental health conditions, including depression. And I think we see this quite a lot in research, where this comorbidity is often excluded within research to help identify better solutions. And of course, we need more research that includes people with mental health conditions. Do you see this as as quite a big barrier to advancing our knowledge around this space? And is this something that researchers and research methodology needs to get around? Is how can we include this complexity of patient representation in terms of comorbidity within research? Good. I know you replied in the chat there. What are your thoughts about this barrier, really?
Okay. Thanks, Nathan. And I'm super happy about the discussion in the chat. It was and is very lively, and I think it highlights the reason of the importance of this webinar. Everybody feels the need to bring these fields closer together as science accumulates, as there was a colleague saying in real life, with my patients, you see this holistic thing, and we try to pull them out somehow. So no, I really thank Holly for bringing this in. It is a huge problem for all the field, I think, of mental health, but a lot of fields in medicine, where most of the research, both pharmacology but also psychotherapy research, really tends to exclude comorbidity patients, and basically they're the majority of the real world patients. So there's a huge work to be done to have a better research focus on them and include them in research. So I think terribly important this suggestion, this remark, and if I see to the chat there's so many voices that bringing basically the same. These fields need to be much closer. Maybe later in the discussion we can also abort what it should reflect on training curricula, for example, for psychiatrists or psychologists or doctors who do work in the pain field, etc. Because I think Patrice no doubt have good ideas on what it reflects on training curriculum competencies.
Yeah, and I think those would be really important discussions, building a foundation for people to recognize this in the future, people who are training in these disciplines. Patrice, go ahead.
Thank you. No, thank you so much for the comment. Thanks, first, Holly, for that, yeah, for triggering and the discussion and prompting us. Totally right. I cannot agree more, of course, with all what has been done. An important concept in research, but also in care, is missingness. So missing patients, the ones that are not coming to our clinics, the ones that are missing their appointments. And obviously, we then sometimes annoyed because the agenda is full, and then it makes dealing with the agenda more complicated. But what about these people? And in trials and in research, obviously, participant missingness, what are the ones that are not included? What are the ones that we have difficulties to include? What are the data that are missing? This reflects probably the ones with the high impact pain, with the ones concentrating issues, problems, the one we should focus on. So that's definitely true. That's definitely true. And here, thank you for highlighting the fact that it's, I can't say normal because normal is not the right word, but it's expected not to feel well when having chronic pain. So I would probably feel not well if suffering from that. So I expect that for many, and given the impacts that chronic pain can have on people's life, my mood would be probably quite highly impacted. So it's quite expected. Not speaking about sleep. Sleep is quite constantly, or at least consistently impaired in many people living with a chronic pain. And Anna has mentioned also the problem of substance use disorder. 20% of the people taking opiates may have a substance use disorder. It's not because they have a propensity necessarily themselves to be addicted. We're not speaking about addiction. Addiction sometimes can happen, but it's pretty much expected that for many, drugs can induce problems in their life. Like pain can induce problems in their life. Drugs can be sometimes solution, but can or have to be considered in the full picture to be sure that we correctly address things. And correctly address things is first of all acknowledging that, documenting that, investigating that. So it's definitely an important call for better research, more data, better education, more education to be sure that it's addressed. And it's addressed by the pain world, but also much further than that. And that's why, again, we together with the mental health world, and that we can also support not only patients, but also our colleagues who may feel, again, disempowered or not well informed. So that's all that are important aspects. So thank you for the comment. Can't agree more.
Yeah, and I think this recognition, the core concept there that you mentioned, that's exactly what this platform can do, and the SIP platform, and obviously the work that all of our colleagues are doing. It seems like the onus, of course, to really recognize this becomes on the healthcare professionals, and that usually stems from their initial training. Whenever they're conducting their training, they're being educated about clinical practice, how to deal with these cases. Exactly, and perhaps Anna can give us maybe an insight into this. And maybe everybody in the chat, you can reflect on what type of education you've had in your discipline with regards to the connection between chronic pain and mental health and how to manage that. What does this look like in education for perhaps a psychiatrist going through training? Is there much onus placed on the concept of chronic pain, the influence that has, or is there nothing really? What was the training like?
That's a difficult question because the answer is simple, but I really feel very sad voicing it because there's very little training on it. Well, I was fortunate to also do research work and do the PhD, so I had some additional opportunity to learn more. But within the basic curriculum and psychiatry, unfortunately, in our country, we don't have any focus on the pain or chronic pain whatsoever. And that is not only the case for us, because there are studies from, for example, the United States, which show that only, I don't want to give you bad exact numbers, but I think there's several hours at best on pain education within the whole psychiatric curriculum. And it is sometimes incorporated just a little bit into the addiction management or into the consultation liaison psychiatry. But that's generally the data, and it shows that there is very little education in that. And I really think we need to change that to improve the outcomes for our patients.
And it kind of reiterates some work that we've done recently at EFIC, mapping pain education across Europe, across physiotherapy, nursing, psychology, and medicine curricula. And in the psychology aspect, you're absolutely right. It's really difficult to try and identify some real comprehensive delivery of pain education across undergraduate and postgraduate curricula. So, is it that we expect people to be able to work well and deliver these types of interventions despite not having the training? I guess this is where interdisciplinary and multidisciplinary approaches to pain management comes in, and really establishing connections with colleagues and systems that can support you in those areas that you were perhaps not as well established.
Yeah, I mean, it's good that you're bringing that up because there is an interesting work, which is a survey of program directors in psychiatry coming from the States. And they cited this as a reason for this lack of pain education among psychiatric trainees, that they don't have the staff to actually do the training because there aren't people who would be psychiatrists trained in that particular area. And not everyone has the collaboration with pain specialists. So yeah, that is a great issue too.
The double-edged sword, we like to say.
Exactly.
But of course, identifying it and the works to identify that are important, and then thinking about those really simple strategies. There's nothing simple about it, but I think is the way forward for that. And yeah, reflecting on training is perhaps inadequate with regards to really connecting this and being the best that we can in this space. I want to bring it just very quickly. We have a sort of 8 minutes left to Elian's question in the chat, which I think, Anna, you might have begun to kind of think about that, which was, are there specific questionnaires that score for the higher risk patients of acute pain becoming chronic pain? Is there any resources that our audience can use? I'll take that to the floor. Gert, Anna, Patrice, what kind of resources can everybody use to help identify that?
I think Anna put some very valuable advice in the chat, so I leave this up to her to respond.
Yeah, I mean, generally the model in which we understand the psychological background accompanying this transition from acute to chronic pain is based on the fear avoidance model. And it has been updated a bit in the past years, refined a little. So there are some older questionnaires which assess the problems linked to that model, like kinesiophobia, avoidance, pain catastrophization, and such phenomena. And there are some newer questionnaires. Unfortunately, I don't think there is a specific guidance in which questionnaires would be more suitable for the time being.
Yeah, and if I can expand on that, so we definitely know that that kind of model and concept is absolutely central in the risk of pain chronicization. It's more difficult to actually say how to operationalize that, and what is the not only the value of the questionnaire to screen and to stratify people, for instance, the potential participant in a trial, but in fact these trials have been quite limited in terms of the impact of screening based strategy. So to what extent we can modify the trajectory by targeting these people in particular. So definitely there is a need for more research, not only to understand and to identify people, but actually to personalize care and to be sure that we can actually support them better. The second point is the difficulty also when speaking about operationalizing that and implementing these questionnaires in a practice is that the population at the start is quite large. And if we speak about acute pain and, for instance, acute postoperative pain, it's time consuming. It's resource intensive. Of course, the questionnaires are not necessarily super long, but the training and the correct implementation is important to that also, to be sure that people do not feel stigmatized. An example is, for instance, the debate that has occurred about the pain catastrophizing questionnaires, because people do not necessarily want to be labeled as catastrophizers, and I can easily understand that, of course. So that's not yet closed to know how to deal with these different aspects. One important aspect is going back to the importance of raising awareness on that issue. So it's not only about a questionnaire, but it's about going back to the patient, especially if, for instance, a major surgery is expected to happen, or particular vulnerability factors have been identified. So going back to these people and, are you worrying about something? Are you worrying about pain in particular? What about you? And encouraging our colleagues and ourselves as well, going back to these patients after surgery to be sure that they feel supported and that we can adjust, because not having necessarily the one size fitting all or the ultimate recipe, making it possible to improve quality of pain management for all, but making it sure that we can adjust and that we can accompany these people to improve outcomes, but also to protect their experience and to be sure that the experience itself is not too poor, and that they do not feel like we sometimes hear that they do not feel miserable in pain and not accompanied as they should. So it's a balance between the basic aspect, and that's to some extent also an answer to some of the questions, basic aspect of pain management. So looking at the simple things that we should do and the error that we shouldn't do. So not neglecting the importance of that, and the more advanced strategies when calling a colleague, more specialized one, or being available for colleagues when things are potentially more complicated, and not just complex, but complicated because not necessarily anticipated as they could have been. So hopefully it's an answer, even if it's also an answer that more research is needed to clarify and to be and to offer solutions that are ready for purpose. So it's for the moment much about you all, what you can do, being in front of a patient exposed to a particularly challenging situation.
And I think on kind of that note, the horizon is positive in that there's a better recognition, and the advocacy efforts for mental health links with all sorts of NCDs or pain specifically is increasing. And I think with that comes better management, better diagnostic pathways, better support systems for these people, but then also the increased complexities and the research that comes out and probably gives us more questions than answers. But I think there's a lot of stuff moving forward, and of course on today, World Mental Health Day, reflecting on this is really important for us. So thank you for everyone for being involved. I think we could go on for another hour or so, I think, with these discussions. They are fantastic. So thank you for these important points. And I apologize that we've not been able to get through the specific parts within the chat, but it certainly seems like there's lots of really important and really interesting work. Some are already in press, some are in the middle of data collection. There's some really interesting work happening. So I think we all need to keep our eyes out on the horizon for this. I'd love to give the floor for final thoughts to each one of our panelists today. So perhaps, Anna, we can come to you just clockwise on my screen. That's how we usually kind of go about this. But any sort of final thoughts, key takeaways that you'd like our audience to go away with today?
I think that key takeaway for me would be that we really have a lot to offer for people with chronic pain, and that we also, I'm sorry, I'm trying to gauge whether to talk to the psychiatrist more or to the other specialists. But I think for other specialists, we really can be very helpful in managing people with chronic pain. And we are absolutely open to collaboration. But for people who are in psychiatry, we really need to have more training on that regard. So that's a dual message for the dual burden. Thank you.
It's a strong message. And Kurt, maybe we can come to you. What are your kind of overriding thoughts about this?
Okay, very short. I think there's a growing collaboration, so that's good. And as I think I would invite everybody, talk with colleagues and let this movement grow. There's been said a lot of interesting things, and indeed science is coming together. I think research, I think step by step, a little bit, also education, training, but never forget, in real life, we need real money. And I would raise this, we didn't discuss this today, but to have real multimodal pain management, interdisciplinary, you need good reimbursement systems. So I would invite everybody also not to think only about the research and these things, but also lobby and advocate in their different countries for better reimbursement systems for this multimodal pain approach. So, but I'm a very practical person, so have a good day.
Brilliant. And Patrice?
Echoing Geert and Anna, we're definitely stronger together. My message is simple. We need you all. So do not hesitate to get back to us. Very happy to collaborate, to support you, to share experience, and to learn from you as well. What does work, what doesn't. That's important. You have fantastic examples, certainly being super interesting for others. But we can also share materials, ideas to be sure that lines are moving and moving in the good direction. Thank you.
Yeah, and I think that's exactly what we need to do. We can continue these discussions, and in the chat there you can see a link to our Discord, which is a brand new platform that EFIC have created to provide a space for people to discuss topics that we put to the community. And of course, today I think has been so fruitful. So please use that link to join our Discord and continue the discussions there. And of course, thank you so much for being involved today, everyone, our panelists. I think the discussions have been really fruitful, and of course want to thank the panelists, but also want to thank the audience for taking time for being involved and sharing your insights and thoughts. As I mentioned before, this webinar is recorded, so you will be able to access from the online platform of EFIC, the Academy, and the YouTube channel, but also from our partners today as well. So please share the resource and have everybody watch that. But thank you for joining us live here on World Mental Health Day. And thank you so much for being involved. And we shall see you again on the next one. Thank you so much, everybody. Have a great rest of your day.
Thank
Thank
you.
you.
Thank you,
much.
Nathan. Thank you all.